Thank you, Armenia, for your nice introduction. It's actually my pleasure to be one of your best friends. And it's my pleasure to be a part of the SIOP 2023. And I'm sorry that I didn't have the chance to come to Yerevan this time in person. And I'm planning to present about approach to congenital neutropenias. So I should mention, as you know, the phagocyte defect is the most important part of the immune system, and it seems that neutropenia is one of the most common defects in the phagocyte defects. And as you know, neutropenia is defined by absolute neutrophil count of less than 1,500, which could be classified into three groups of severe neutropenia to less than 500, 500 to 1,000 as moderate neutropenia, and 1,000 to 1,500 as mild neutropenia. If you have a look at the life cycle of the neutrophil, you can see at the left side we have this is bone marrow that poor myelocyte should mature to myelocyte and then neutrophil. So if we have some kind of arrest to poor myelocyte at the earlier stage, it leads to severe neutropenia, severe congenital neutropenia. And if we have enough absolute neutrophil count, but they have some defects in rolling in the circulation, the name of disease would be leukocyte adhesion defect due to defects of beta-2 integrin. And if there will be some problem in the digestion of the pathogen, the disease will be chronic granulomatous disease or CGD. So neutropenia could be classified into two groups of congenital and acquired. There are several etiologies for acquired neutropenia, like infection, malignancy, malnutrition, and immune-related increased destruction. And for congenital neutropenia, I can classify it into non-syndromic neutropenia, neutropenia plus oculocutaneous hypopigmentation, plus pancreatic insufficiency, plus combined immunodeficiency, metabolic disease, bone marrow aplasia or infiltration, and other syndromic neutropenia. And for acquired neutropenia, as I mentioned, some infections, cancers, malnutrition, and immune-related increased destruction could be the causes of acquired neutropenia, which is not the part of my lecture. If you have a look at this slide, you can see that there are several diseases on the umbrella of the congenital neutropenia. For example, in non-syndromic neutropenia, I can mention Castman syndrome and severe congenital neutropenia, which could be in either form of autosomal recessive, autosomal dominant, and X-linked neutropenia. There are a few diseases under the umbrella of the oculocutaneous hypopigmentation, like Chiediac-Higashi syndrome, Griscelli syndrome type 2, Hermansky-Pawlak syndrome type 2, and P14 deficiency. Neutropenia plus pancreatic insufficiency, I can name Schwachman-Diamond syndrome, CD40 ligand deficiency, WHIM syndrome, reticular dyskinesia are part of combined immunodeficiency plus congenital neutropenia. Glycogen storage disease type 1b is a metabolic disease associated with congenital neutropenia, and I can also name GATA2 deficiency and dyskeratosis congenita as a part of neutropenia and bone marrow aplasia. There are also some other syndromic deficiency like G6PC3 deficiency and Cohen syndrome. So if you, had a look at this diagram, you realize that there are several inborners of immunity which are associated with neutropenia. And the prototype of disease is severe congenital neutropenia, which is also named as Castman syndrome. As you know, Dr. Castman introduced Castman syndrome or severe congenital neutropenia in 1956 in patients with early onset recurrent bacterial infections and earlier stage maturation arrest of myeloid differentiation. So the patient usually suffer from some, abscesses in different organs, especially in the oral cavity and also anal lesions. And they also suffer from respiratory infection and GI problems as well. Severe congenital neutropenia seems that this is the multi-gene disorders. Just 2 decades ago, it was believed that ELANE or ELA2 was the only gene responsible for sporadic or autosomal dominant of disease. But in 2007, we realized that HAX1 is responsible for autosomal recessive of congenital neutropenia. So we had the chance to be part of this study, and we published this paper in Nature Genetics in January 2007. Later on, we continued our studies in the field of neutropenia because, there were half of neutropenic patients without mutation in HAX1 and ELANE. And we realized that there are some other genes like JAG1 and G6PC3. And if you have a look at this diagram, which we published this paper just a decade ago, HAX1 has two transcripts. If one transcript is involved, it leads to just a hematopoietic manifestation like neutropenia. And if two transcripts are involved, it leads to some extra hematopoietic manifestation like neurological problems. So we had a patient with a stop codon mutation in HAX1, and the patient also suffered from some epilepsy and neurological disorders in addition to neutropenia as well. So this is another patient which suffered from who suffered from cardiac and congenital malformation, and the patient again had severe to moderate neutropenia. And if you have a look at this table, you realize that, for example, this column, cardiovascular system and neutropenia. So there are a few diseases here, and we realize that this patient has a homozygote mutation in G6PC3 gene. So we published this paper in 2009 in the New England Journal of Medicine as a new syndromic neutropenia with cardiac malformation and also congenital malformation and also congenital neutropenia. We continued our studies about apoptosis of the neutrophil, and we found that the JAG1 deficiency is another gene which is responsible for congenital neutropenia. And our recent study, which was published just a couple of months ago in 2023 in the Blood Journal, we showed that SRP19 and SRPRA are two genes. The second one is autosomal dominant, which is a heterozygote mutation, de novo mutation, and this is the autosomal recessive disease. Both genes are also responsible for severe congenital neutropenia. It was, the 6 years of studies in a group of patients, and we showed that these two genes are also responsible for, severe congenital neutropenia. You have also heard about cyclic neutropenia, which could last about 3 to 6 days, and there is a cyclic variation in 3 weeks, and it's usually associated with, ELANE or ELA2 mutation. As I mentioned, some patients with neutropenia are also associated with oculocutaneous hyperpigmentation. I can name Chidiac-Higashi syndrome, Griscelli syndrome type 2, Hermann-Cipollard syndrome type 2, P14 deficiency, polydin deficiency, and VC syndrome. There is no need to perform exome sequencing for all of these patients. For example, we could do some simple studies like checking the hair shaft in the electron microscope, and you can see the difference. For example, in Chidiac-Higashi syndrome, they have disturbed regular melanin, but in Griscelli syndrome, they have large irregular melanin, and the giant granule here, the giant intracellular granule can only be found in Chidiac-Higashi syndrome. So there is no need to sequence, 60 large exons to find the causative mutation. We could just do the peripheral blood smear and check the hair shaft to distinguish between these disorders. This is the light microscopic hair shaft. This is from Chidiac-Higashi. This is, completely disturbed regular melanin. And this is the Griscelli syndrome. You can see this is, irregular. And this is the control hair shaft. Another disease, WHIM syndrome, which is very important, especially for, some hematologists, because the patients usually suffer from neutropenia because of myelokathexis. They have infections, and if we check the IgG, IgM, and IgA, we will find that the patient has hypogamma as well. But some of them might suffer from warts later. So I can name the disease as a WHIM or HEM or 6HER4 deficiency because warts can be found later in these patients as well. Shwachman-Diamond syndrome is another disorder. They usually suffer from myelodysplastic syndrome, and they could also suffer from acute myelogenous leukemia as well. The main phenotype of disorders is exocrine pancreatic insufficiency, and they suffer from some skeletal abnormalities like pectus cavernous as well, and they have some neurodevelopmental delay as well. This is the sonography of a patient with Shwachman-Diamond. So you can see that this is the white pancreas. So this is the lipomatous pancreas, and they suffer from pancreatic insufficiency. Cartilage hair hypoplasia is another disorder with metaphyseal chondrodysplasia, hypoplastic hair, and they could also suffer from neutropenia as well. And as I mentioned earlier, there are some other phagocyte defects which could be associated with neutropenia, like Bass syndrome, Cohen syndrome, and poikiloderma with neutropenia. And there are some other PIDs, not phagocyte defect, like CD40 ligand deficiency. I mean, I had at least 30 patients with CD40 ligand deficiency who suffered from neutropenia at the first presentation, reticular dyskinesia and sclerosis congenita. And these are the list of, other PIDs associated with neutropenia. It's very easy to find neutropenia. As you know, it's very simple and cheap to check the CBC. I mean, unfortunately, some of the patients usually suffer with infections to outpatient clinics, and the GPs just, prescribe antibiotics without checking CBC. So it's very easy to check the CBC and find that the patient has neutropenia, and this patient should be referred to hematologist or clinical immunologist, while early diagnosis and appropriate treatments are the keys to survive the patients with neutropenia. So we should exclude other causes of neutropenia, as I mentioned in the earlier slides, and we could check the secondary neutropenia, and we could perform bone marrow to check if the disease primary at bone marrow or not. After bone marrow examination, we could check some immunological studies to exclude other imbalance of immunity associated with neutropenia, and we could perform genetic studies to make definite diagnosis of neutropenia. There are some debates about management of the patient. In our settings, I usually prescribe prophylactic antibiotic like cotrimoxazole and also GCSF. We also developed the Pegagin. This is a pegylated GCSF every 3 weeks for the patient with neutropenia. And there is no need to perform HSCT or BMT for all the patients with neutropenia. Those who do not respond to GCSF, those with continuing severe bacterial infections, or those who complicated with myelodysplasia are the indication of HSCT for the patient with neutropenia. And it has been advised that this patient should be followed up at least twice per year. Dental follow-up and gingival care are necessary. Checking CBC every 3 months. Repeated bone marrow examination for checking GCSF receptor mutation is also necessary every year. And GCSF receptor analysis for the patients are also necessary. So this is, one of the main approach to congenital neutropenia from the beginning, because every patient with infection and abscess, we should check CBC. If the patient has normal absolute neutrophil, we could think about leukocyte antigen deficiency if there is a defect in chemotaxis test. And if the patient has defective MBT or DHR, we should think about CGD. But if the patient has severe persistent neutropenia, we will look for other, complication in other organs. So it could be either syndromic or non-syndromic, and we could approach, as I mentioned earlier. If you are interested in the field of imbalance of immunity, this is the second edition of the Primary Immunodeficiency Diseases textbook. The third edition will be published in 2024. And I should highlight this point that just 1 decade ago, the number of imbalances immunity was 150. In the second edition, there were, more than 300. And now in our new edition of the book in 2024, there should be more than 500 diseases. So the number of diseases from 150 have been increased three more times to more than 500. It shows that how much is important that we should keep us updated about this field of diseases, which is a joint field of immunohematology. There are some other disorders about the pediatric immunology and pediatric autoimmunity, and I'm also editing the comprehensive hematology and stem cells. If any of you are interested to join in drafting some chapters, I would be more than happy to consider your proposal. And these are some other books. We also developed the USER network, Universal Scientific Education and Research Network. So if any of you are interested to international collaboration, we would be more than happy to have you as a free member of this network. And finally, I really hope that I come to Yerevan again in November 2023 for the 8th International USON Congress. And I would like to invite all of you to encourage your patients to send us their paintings for the 9th International Festival of Painting for Pediatric Patients. I should acknowledge all my junior colleagues who are helping me in the research and the clinics to make the diagnosis of this patient, especially neutropenia patient, to provide better quality of life for this group of patients. Thank you for your attention. If you have any question, I would be more than happy to answer.